Okay, this is going to be a case study review. It'll hopefully help you guys review modules 1 and 2. Tanya is our first person. We have Tanya and Betty that we're going to talk about. Tanya is an 18-year-old sexually active girl. Her mother brings her in for the HPV vaccine. What are Tanya's options? So one of the main vaccines we use is Gardasil. It used to only be available for 9 to 26-year-old females, and now it's available for females and males, and it's actually available all the way up to age 45, if that's not crazy. What are the dosing recommendations for Tanya? So the reason why we talk about this is because dosing recommendations actually change depending on what your age is. So between 9 and 14, we say 2 doses. Above 14, we say 3 doses. And Tanya's boyfriend can get it as well. So Tanya and her boyfriend are considering contraceptive options because remember we said that they were sexually active, right? Tanya is very interested in oral contraception. What are teaching points for combined oral contraception? So remember, combined oral contraception, one, can cause venous thromboembolism, right? So what does that mean? That means blood clots. So what can that affect? That can cause deep vein thrombosis, right? DVTs, pulmonary embolism, myocardial infarction, stroke. So we would want to teach her about all of those signs and symptoms. We also would want to teach her that if she's taking any medications that can decrease its effectiveness, like certain antibiotics, antifungals, and anticonvulsants, that she would want to use a backup method during that time. What are contraindications for combined oral contraceptives? So go back to that venous thromboembolism. So anything that increases your risk of having a venous thromboembolism would be a contraindication. So things like smoking, hypertension, heart disease, being above 35, all of those increase your risk for a venous thromboembolism. So it would make it contraindicated for her to get contraception if she had that, or oral contraceptive. Tanya's boyfriend, Keith, asked about recommendations for condom use. He's really curious about the spermicide stuff that he heard, Noxil 9, and the use with condoms. Will it decrease Tanya's chances of getting pregnant? It will not. So Noxil 9 does not decrease their risk of getting pregnant. In fact, it can cause damage to their skin, which increases their risk of getting HIV. So Noxil 9 is not recommended for the use with condoms. So we're going to talk about Betty. Betty is Tanya's best friend, and you can see in my little picture of Betty White. She's like my favorite. So Betty, Tanya's friend, comes in with dysuria. Betty reports that her boyfriend contacted her and stated that he was treated for an STI infection. He doesn't remember whether it was gonorrhea, chlamydia, or chlamydia, but states Betty should be seen. Now, Betty is concerned about the dysuria. What type of assessment should be done for Betty? So our next picture, I like to be able to kind of talk about this. The first time I taught this class, I did not teach that slide specifically. So just to kind of review it, what would we want to do if she had gonorrhea and chlamydia? So we would typically do something called a sterile speculum exam. So if you're looking at A, that would be the position that we put the patient in. And we would want to visualize the cervix and take a sample. This is also what we would do if we were doing like a pap smear, or if we were, assessing somebody that came in for bleeding. So a lot of times when we think about bleeding and pregnancy, we say something, and you'll hear me say it throughout the whole entire time, that we put no hands in the vagina. No hands in the vagina. That means no sterile vaginal exams with our hands, no cervical checks. That doesn't mean no sterile speculum exams. A speculum exam is where you open up the vaginal wall to be able to visualize the cervix. You don't touch the cervix with a speculum exam. So that would not be contraindicated. Okay? So we would do a sterile speculum exam and take a sample. So that's what they did. They did a GCCT, which is a gonorrhea and chlamydia test. The nurse explains that Betty should begin treatment before results come back. Why do you guys think? So here's the thing. CDC recommends that we co-treat for gonorrhea and chlamydia. Chlamydia you don't necessarily have the signs and symptoms. Gonorrhea, you actually do have some signs and symptoms with gonorrhea. So if you present with gonorrhea, we recommend to treat with chlamydia automatically. Here's the thing. So gonorrhea and chlamydia can cause damage to the fallopian tubes, which can increase the risk of infertility. So that's one of the reasons why we want to go ahead and treat both of them at the same time. Chlamydia can be treated with azithromycin and doxycycline. Those are two of the more common ones. There's a few different antibiotics though for chlamydia. Gonorrhea, gold standard is ceftriaxone. So a lot of times we're going to do ceftriaxone and something else, azithromycin, doxycycline, but ceftriaxone has been the most effective against gonorrhea. Ooh, Tanya is 23 years old now, so she reports nausea and amenorrhea. She thinks she might be pregnant. Are these signs presumptive, probable, or positive? So, presumptive is felt by the mom. Amenorrhea, which means the cessation of her period, is a symptom felt by the mom. Nausea is a symptom felt by the mom. So these are both presumptive. What about probable? So probable is if anything that's felt by the provider. So for example, like a Blotman test, a Goodwick test, Goodell test. Those are, Chadwick, sorry. Those are signs of, probable signs of pregnancy. So felt by the provider, but not confirmed by the provider, right? Like seeing like the bluish tint on their cervix, that kind of stuff. Being able to like kind of bounce something, that's the ballotment, you know? So those are felt by the provider. Another probable test that most people, including me, wouldn't really think is a probable test is a positive pregnancy test. That always throws me off because I'm like, it says positive in the name. Why isn't it a positive sign? But it's not. Why? Because other things can cause a positive pregnancy test, not just being pregnant. So sometimes cancer can actually cause a positive pregnancy test. Sometimes chemical pregnancies could also be a positive pregnancy test. And then one of the things we learned about molar pregnancies, you're not pregnant, right? You don't have a fetus. You have these rapidly dividing cells. So that would be why that they're a probable sign. Positive signs are actually confirmed by the provider with something else. So I have an ultrasound, I have a heart rate, I have a clear idea that there's nothing else that could have caused this other than a baby. So, like for example, I have my hands on the belly and I can literally feel that there is an entity inside that belly moving all around. I'm not just able to like, well, I feel something that kind of feels like a fetus. It's like, no, there is nothing else that could cause this. This is definitely a baby. Positive. So Tanya sees a fetus on the ultrasound. That's a positive sign. Woo. Now Tanya's giving birth. That one really fast. Tanya's giving birth to a beautiful 7-pound, 6-ounce baby girl at 39 weeks. Woo, she's so cute. You see Tanya 5 years later. During this time, Tanya reports that she had 1 miscarriage and gave birth to an infant at 35 weeks with trisomy 18 that died 5 days later. Tanya reports she's trying to get pregnant again. What's her current GTIP PAL? So she had her baby that we just saw. She had a miscarriage and she had a baby born at 35 weeks. So she's a G3. She had the 1 full term, 1 preterm, 1 miscarriage, and 1 baby still alive. Tanya calls a month later and states she had a positive pregnancy test. Yay! She's scheduled for a 10-week appointment. What type of ultrasound would be recommended at the 10-week appointment? So we would do a transvaginal ultrasound. If Tanya's pregnancy is confirmed, what would be a positive sign of pregnancy? So seeing that baby on ultrasound would be a positive sign. And what's Tanya's GTIP PAL? It's now 41111, right? What kind of tests are recommended for Tanya during this pregnancy? So she has a baby, she's had a baby with trisomy 18, so we'd probably want to recommend a test related to that, right? So what are some of the non-invasive tests? So doing that non-invasive prenatal testing actually tests for a baby's the fetal DNA in the maternal sample. It blows my mind still. And that helps them test for things like trisomy 13, 18, 21, sex chromosome, genetic disorders, so other things like that. So that is kind of mind-blowing. They were able to do that, and it's very non-invasive. The invasive tests, you're thinking about the percutaneous umbilical, blood sampling, pubs, the chorionic villi sampling, amniocentesis. So those are very invasive. We wouldn't recommend those first if we could do the cell-free DNA testing. The amniocentesis is definitely one of the most invasive ones and highest risk. The reasons why we still might do it for other reasons would be if we thought there was an infection, so we could do a culture and sensitivity on the amniotic fluid. If we were trying to test the fetal lung maturity, that also might be a reason that we would do the test. Just to touch on the fetal lung maturity. So what we're looking for is the amount of surfactant. So we can actually test like how much surfactant this baby has made. That's why it's effective. So Tanya's going to get a non-stress test. What are non-stress tests? And remember, they're 20-minute long tests. We're looking for moderate variability and 2 accelerations with no decelerations other than earlies because they're okay, right? Tanya's 32 weeks pregnant. She's a G4P1 or 41111. Tanya reports to her stress test. She has a fetal heart rate of 170. What's normal? 110 to 160, right? Her non-stress test is non-reactive. What assessment tool would likely be used to evaluate Tanya? So the next step up would be a biophysical profile. Okay, that's what we do. Tanya's 37 weeks pregnant. She gets non-stress tests, weekly biophysical profiles, and Doppler studies due to her concern that her baby has intrauterine growth restriction. Tanya's provider is planning to induce her labor but would like to see if she can tolerate labor. What assessment tool would give the provider more information? Contraction stress test, right? So what causes a contraction stress test to be positive? So if we see late decelerations with contractions, that would be a positive contraction stress test. So that would not be good. Okay, our next person, Betty. Betty arrives at your clinic with her best friend, Tanya. Betty thinks she's pregnant. She reports that she's had 1 elective abortion and 1 miscarriage. She thinks she's pregnant because of a positive pregnancy test. You see a fetus on the ultrasound. So what's Betty's GTPAL? So she thinks she's pregnant. We just confirmed it. She's had 1 elective abortion and 1 miscarriage. So it's her 3rd pregnancy. So she's a G30020. Betty reports that the father of the baby is not involved and has a new boyfriend. What are teaching points for Betty? So big time, we'd want to teach her about STI prevention. So condom use would be really, really important. The risk of baby if her partner had anything like gonorrhea and chlamydia. The risk for a baby if her partner had HIV, syphilis. These are huge risks for baby. Even if the partner just happened to be in an area that had the Zika virus and got bit by a mosquito, that's a huge risk for baby. So having them use condoms during that time would definitely be important. Okay, so Betty has a BMI of 31. What are teaching points for weight gain for Betty? So we would recommend only 11 to 20 pounds because she's considered in the obese category. Okay, so above 30 is obese. Between 25 and 30 is overweight, and then between 20 or 18.5, I've also seen it, up to 24.9 is considered normal weight. So we see it on that slide. So that always determines how much they can gain. So 25 to 35 is your normal, 15 to 25 is your overweight, and 11 to 20 is your obese. Betty is now 16 weeks pregnant. She arrives to your clinic and reports that she has a painless chancre-like sore in the genital area. What are concerns for Betty? So what do we think she has? If you were thinking primary syphilis, you would be correct, right? So primary syphilis is just that painless chancre-like sore in the genital area. Secondary syphilis is when it's spread, right, to your hands, to your torso. You have a rash everywhere. It's systemic. Latent is where it kind of goes away, but like stays just waiting to come back out. And then your tertiary is when it starts to affect your brain and your organs. So what are treatment options for Betty? Penicillin. So if they are pregnant and they have syphilis, the only recommended treatment is penicillin, regardless of allergies. It's penicillin. Allergies, we desensitize you and you're going to get it anyways. Betty is postpartum. She's interested in contraception. She has a history of hypertension in pregnancy and she smokes. What might be contraindicated for Betty? Remember, we talked about this. The contraindications for combined oral contraceptives would make it to where she should not get a combined oral contraceptive with hypertension and smoking. Okay. Betty decides on an IUD. What are risks for an IUD? So IUDs, of course, increase your risk for ectopic pregnancies. They also increase your risk for pelvic inflammatory disease, right? Betty is 3 weeks postpartum. She has severe abdominal pain, cramping, and is febrile. The provider suspects pelvic inflammatory disease. So what are risk factors for pelvic inflammatory disease? Endometritis would also be a good consideration for this. I'm not going to decide right now in this moment why they would pick pelvic inflammatory disease over endometritis. I can see how they could both be connected. And really, I guess if you're looking at it and you see the inflammation going outside of the uterus, that would probably be a good reason to call it pelvic inflammatory disease as opposed to endometritis, because endometritis would just be the endometrial tissue. But I could see both. So she's got abdominal pain, cramping, and is febrile. And remember, for pelvic inflammatory disease, yes, the greater the partners, the STIs, all of those increase your risk factors. The IUD increase your risk factors, but also miscarriage and postpartum, they can end up with pelvic inflammatory disease as well. You as the new nurse are curious why the provider is giving her an oral antibiotic. The last patient was admitted. What might be reasons to admit versus sending home? So that is something that you kind of struggle with sometimes as a newer nurse, especially, of like trying to understand, like, why are they doing this when they did this for another person? So with her, you're looking at her, she's got only 100.4 temperature. So we typically will try to do an oral antibiotic as long as they're stable. We'll try to do an oral antibiotic and send them home. That way they're not, putting themselves at risk for hospital-acquired infections and all the other things that can happen from being admitted. And then if it does not knock out the infection and they need to come back in, then we would go ahead and admit them. If it gets worse, if it's not effective, then we'd admit them for IV antibiotics. Okay, well, that is all of this lecture. So I hope this helped, and it was just a quick review. But I hope it kind of gave you a few teaching points and helped you put it all together. Okay, thank you.